Welcome to the Deep Dive. We're here to help you cut through the noise and get straight to the essential knowledge you need, fast. And if you're a nursing student, well, the nervous system chapter can feel pretty overwhelming, especially when you're prepping for clinicals or the NCLEX.
It really can. It's dense stuff. But understanding it isn't just about theory, right? It's about what you see and do at the bedside every single day.
Exactly. So today we're diving into that crucial chapter from Lewis's Medical Surgical Nursing 12th edition Assessment and Management of the Nervous System, our mission, to help you quickly grab the core structures, functions, assessment techniques, and those key diagnostic studies. Make it clear, make it stick.
Absolutely. Think of the nervous system as the body's ultimate conductor. Knowing what's normal is, well, critical for spotting the abnormal. That's nursing in a nutshell.
So expect us to break it all down, from tiny neurons up to the brain and spinal cord. We'll cover assessment, what goes wrong, the tests.
And we'll use a case study, JK, to really bring it home, show how those symptoms connect right back to the underlying issue and guide what we do as nurses.
Perfect. Let's jump in. First stop, the absolute basics, the nervous system's main divisions.
Right. You've got two big parts. First, the central nervous system, the CNS, that's the brain, the spinal cord, and actually cranial nerves 1 and 2, the olfactory and optic nerves. Think of it as the control center, the mainframe.
Okay, the mainframe. And the second part?
That's the peripheral nervous system, the PNS. This is like the network of cables and sensors branching out. It includes cranial nerves 3 through 12, all your spinal nerves, and parts of the autonomic nervous system, basically connecting the mainframe to everywhere else.
Got it. And zooming in closer, the building blocks are neurons and glial cells.
Exactly. Neurons are the stars, the communicators. They have 3 key traits. Excitability, they can generate an impulse. Conductivity, they transmit that impulse. And influence, they talk to other neurons or muscles or glands. Structure-wise, you've got the cell body, dendrites bringing signal in, and the axon sending signals out.
And that axon often has a covering, right? The myelin sheath.
Yes, and this is super important. Myelin is a fatty protein layer that acts like insulation. It makes the nerve impulse travel much, much faster.
How much faster?
Dramatically faster. The impulse literally hops between gaps in the myelin. We call it saltatory conduction. It's why you react so quickly. And clinically, damage to myelin, like in MS, really messes up that communication.
Okay, so if neurons are the communicators, what about the glial cells? You call them neurolia too.
Right. They are the essential support crew, the unsung heroes. They nourish, protect, kind of keep the environment right for the neurons.
Like different types of crew members.
Exactly. You have microglia, which are like tiny vacuum cleaners engulfing debris, especially after an injury. They're phagocytic.
Okay, the cleanup crew.
Then you have the macrolia. Big ones here are astrocytes. They give structural support, help form that crucial blood-brain barrier. We'll definitely come back to that. And they form scar tissue after injury, a process called gliosis.
Gliosis, scar tissue of the brain. Got it.
Also, oligodendrocytes make myelin, but specifically in the CNS. And ependymal cells line the ventricles and help make cerebrospinal fluid.
So different support roles. What about nerve damage? Can nerves repair themselves?
Well, there's a key difference. PNS neurons, especially if their cell body is okay, and they have help from Schwann cells, which make myelin in the PNS, they can regenerate pretty well.
Okay.
CNS axons, though, much tougher. Regeneration is limited. That's why spinal cord injuries are so devastating. But there's ongoing research into neurogenesis, making new neurons, which offers some hope down the line.
Interesting. So we have the cells. How do messages actually get sent?
It starts with a nerve impulse, that electrical signal, the action potential zipping down the axon. When it reaches the end,
It jumps to the next cell.
not quite jumps. It reaches a junction called the synapse. Think of it like a tiny gap. The message has to cross that gap chemically.
Chemicals. Neurotransmitter.
Exactly. These are the chemical messengers. Some are excitatory, like epinephrine, norepinephrine, glutamate. They make the next cell more likely to fire.
Okay, rev it up.
And others are inhibitory, serotonin, GABA, dopamine. They make it less likely to fire, calm it down.
So it's a balance.
A critical balance. And you have specialized ones too, like endorphins blocking pain or substance P increasing pain signals. This is why drugs and toxins have such huge effects. They mess with these neurotransmitters or their receptors. Key pharmacology concept right there.
Definitely. Okay, let's dive deeper into the CNS, starting with the spinal cord. You called it the information highway.
It really is. If you slice it, you see this H shape of gray matter that's mostly cell bodies, surrounded by white matter that's the myelinated axons, the highways.
Highways going up and down.
Precisely. The ascending tracks carry sensory information up to the brain, input lines. Knowing these helps us figure out where a problem might be. Like, problems with touch or position sense might involve the fasciculus gracilis or cuneus tracts, pain and temp. That's often the spinothalamic tract.
Okay, sensory going up, so motor commands come down.
Right, through the descending tracts, output lines. The pyramidal tracts are for conscious, voluntary movements reaching for something. The extrapyramidal system handles more automatic stuff. Posture, balance, swinging your arms when you walk, swallowing saliva. Problems here show up in conditions like Parkinson's.
And reflexes, like the knee-jerk thing. Where does that happen?
Right in the spinal cord. That's the reflex arc. Super fast, involuntary response. Tap the knee tendon, signal goes to the cord via a sensory neuron, synapses directly with the motor neuron, signal goes out, muscle contracts, bam, leg kicks, all before your brain really gets involved.
Wow, efficient. Now, you mentioned something crucial for nurses, upper versus lower motor neurons, UMNs and LMNs.
Yes, super important distinction, especially for exams and clinical reasoning. Upper motor neurons start in the brain, in the cerebral cortex, and their axons travel down to influence movement.
Okay, and if they are damaged?
Think spasticity. Weakness or paralysis, sure, but also increased muscle tone, hyperactive reflexes, hyperreflexia, and muscle wasting, mainly from disuse, called disuse atrophy.
Got it. Increased tone, hyperreflexes, and lower motor neurons.
LMNs are the final common pathway. Their cell bodies are in the spinal cord or brainstem, and their axons go directly to the muscles if they're damaged.
It's different.
Completely different picture. Weakness or paralysis again, but now you see decreased muscle tone flaccidity. Reflexes are diminished or absent hyperreflexia or arflexia, and the muscle wasting is much more severe and rapid because the nerve supply is cut off. That's denervation atrophy.
Flaccidity, hyperreflexes. Okay, that difference is key for figuring out where the lesion is.
Absolutely critical.
All right, moving up to the command center itself, the brain. Let's start with the big part, the cerebrum, the thinking cap.
Right. Divided into 4 main lobes. The frontal lobe is your executive suite, higher thinking, memory, planning, voluntary eye, and muscle movement. And crucially, Broca's area for actually producing speech is there.
Broca's for speaking, okay.
Temporal lobe side of the head integrates senses like hearing, visual, somatic data. And it has Wernicke's area, which is vital for understanding language, receptive speech.
Wernicke's for understanding. Got it. Parietal lobe.
Top back part. Interprets spatial info, like knowing where your body is. It's the main sensory processing area.
And the back.
Occipital lobe, all about vision, processing what you see. Remember JK's visual field deficit? That immediately makes you think occipital or maybe temporal parietal pathways nearby.
Ah, connecting the symptoms back. Okay, those are the lobes. What about structures under the cortex? Subcortical.
Crucial ones there. The basal ganglia are deep structures involved in starting, stopping, and smoothing out movements. Also learning, automatic movements like blinking. Think Parkinson's again problems. Yeah.
Okay, thalamus.
The grand central station for sensory input. Almost all sensory info passes through the thalamus on its way to the cortex. Major relay center.
And the hypothalamus.
Yeah.
Sounds important.
Incredibly important. Tiny structure, huge job. Regulates hormones via the pituitary, appetite, body temp, water balance, sleep-wake cycles, even emotions. If a patient has weird vital signs or temp issues, hypothalamus could be involved.
Wow. And the limbic system.
That's more involved with emotion, memory formation, aggression, feeding, sexual response, kind of the primitive emotional brain.
Okay, below the cerebrum is the brainstem.
Correct. Midbrain, pons, and medulla. It's the stalk connecting the cerebrum to the spinal cord. All nerve fibers going up or down have to pass through it. Plus, it houses the control centers for cranial nerves 3 through 12.
And the medulla part sounds vital.
Absolutely. The medulla oblongata contains the centers controlling breathing, heart rate, blood pressure, the vital functions. Also, reflexes like coughing, sneezing, swallowing. Damage here is often catastrophic.
Yeah, you mentioned the RAS.
Yes, the reticular activating system. It runs through the brainstem and is absolutely essential for maintaining consciousness, alertness, and managing sleep-wake transitions. Damage here leads to altered levels of consciousness, even coma. A key nursing assessment focus.
Definitely. And tucked behind the brainstem
Is the cerebellum. Think coordination and balance. It fine-tunes voluntary movements, keeps your posture stable, ensures smooth, coordinated actions. If someone has a clumsy gait or can't do fine motor tasks like buttoning a shirt, you suspect the cerebellum.
All right. Now, protecting all this delicate machinery, you mentioned CSF earlier, cerebrospinal fluid.
Right. It's made mainly in the ventricles, those fluid-filled spaces inside the brain by structures called choroid plexuses. It circulates through the ventricles and then flows out into the subarachnoid space, which surrounds the brain and spinal cord. Then it gets reabsorbed back into the blood.
And it's a job.
Primarily cushioning. It literally floats the brain, protecting it from hitting the skull with minor jolts.
Yeah.
Also carries nutrients and removes waste. We make about 500 millimoles a day, but only have about 150 millimoles circulating at once.
What happens if that system gets blocked?
You get a buildup of CSF, which is hydrocephalus. That increases pressure inside the skull, increased intracranial pressure, or ICP. Measuring CSF pressure during a lumbar puncture or analyzing the fluid itself gives us tons of diagnostic information. Monitoring for signs of increased ICP is a critical nursing function. High ICP can lead to brain herniation, pushing brain tissue where it shouldn't go, which is often fatal.
Critical. Okay, let's zoom back out to the peripheral nervous system, the PNS. You mentioned spinal nerves coming off the cord.
Right. Each spinal nerve has a dorsal root bringing sensory info in and a ventral root sending motor commands out. This leads to two really useful clinical concepts: dermatomes and myotomes.
Dermatomes are those charts.
Exactly. A dermatome is the specific area of skin that gets its sensation from a single spinal nerve root. If a patient has numbness or tingling in a specific pattern, you can often map it to a dermatome and figure out which nerve root or spinal level might be affected. Super useful for diagnosing things like herniated discs or spinal cord injuries.
Makes sense. And myotomes?
Similar idea, but for muscles. A myotome is the group of muscles primarily controlled by a single spinal nerve root. Helps localize motor weakness.
Okay. And then the cranial nerves, 12 pairs.
Yep, 12 pairs. Unlike spinal nerves, they emerge directly from the brain, or brainstem mostly. Some are purely sensory, like optic for vision, some purely motor, like hypoglossal for tongue movement, and some are mixed, like facial for expressions and taste. Assessing these is a core part of the neuro exam.
We'll get to that assessment soon. What's the last part of the PNS?
The autonomic nervous system, the ANS. This controls all the unconscious stuff: heart rate, digestion, breathing rate, pupil size. It has two divisions that often work in opposition to maintain balance.
The fight or flight one.
That's the sympathetic nervous system, or SNS. Gets you ready for action, stress. Uses norepinephrine mainly at the target organs. Think dilated pupils, faster heart rate, mobilized energy stores, slowed digestion. Prepares you to fight or run.
And the other one.
The parasympathetic nervous system, or PSNS. The rest and digest system. Conserves energy. Uses acetylcholine. Think constricted pupils, slower heart rate, increased digestion. It acts more locally.
So they balance each other out?
Usually, yes. It's called dual innervation. Most organs get input from both, allowing for fine-tuned control to maintain homeostasis. Understanding this balance helps us interpret vital signs and predict side effects of medications that affect the ANS.
Okay, fantastic overview of the system itself. Now, how is it protected and supplied with blood? Cerebral circulation sounds vital.
Absolutely critical. The brain needs a constant supply of oxygen and glucose. Blood comes mainly from two pairs of arteries: the internal carotid arteries, front supply, and the vertebral arteries, back supply, which join to form the basilar artery.
And the circle of Willis, I've heard of that.
Right. It's a ring of arteries at the base of the brain connecting these major supply lines. It's designed to provide backup, or collateral circulation. If one artery gets blocked, potentially blood can reroute through the circle.
Eventually.
Yeah, here's the catch. The structure of the circle of Willis varies a lot between people. Some folks have a complete, robust circle. Others have missing or underdeveloped parts. So you can't assume everyone has that protective backup. Important clinical point for stroke risk.
Good to know. And specific arteries feed specific brain areas.
Yes. Anterior, middle, posterior cerebral arteries each supply distinct territories. Knowing this helps predict stroke deficits. If someone has a middle cerebral artery stroke, you expect certain motor and sensory problems, maybe language issues depending on the side. Venous blood drains out through large channels called dural sinuses into the jugular veins.
Okay. What about that blood-brain barrier you mentioned?
Ah, yes, the BBB. It's not a physical wall, but a physiological barrier formed by tight junctions between the cells lining the brain's capillaries, helped by astrocytes. Its job is to be highly selective.
Selective how?
It lets essential things like oxygen, glucose, and CO2 pass easily. It keeps out toxins, pathogens, and many large molecules. Critically for us, it also blocks many medications. Things that are lipid-soluble cross more easily. Water-soluble drugs have a hard time. This is a major challenge when treating brain infections or tumors getting the drugs to the target.
Makes sense. And then the meninges, the layers covering the brain and cord.
3 layers. Outermost is the tough dura mater, then the delicate web-like arachnoid mater. Innermost is the thin pia mater, which clings right to the brain and spinal cord surface.
And the space between arachnoid and pia.
That's the subarachnoid space. It's filled with that cerebrospinal fluid, the CSF. And importantly, this is where we access CSF during a lumbar puncture down in the lower back, where the space is larger and safer to access.
Got it. And finally, the bones.
The skull provides rigid protection for the brain. A key feature is the foramen magnum, the big hole at the base where the spinal cord connects. It's really the only significant opening for the brain to potentially expand downwards if pressure inside gets too high, which is why increased ICP is so dangerous.
And the spine?
The vertebral column, 33 vertebrae, stacked with intervertebral discs between them, protects the spinal cord, supports the head, and allows flexibility. Damage here, obviously, can directly injure the cord it protects.
Okay, that covers structure and protection. What about aging? How does the nervous system change as people get older?
Changes definitely occur, but a huge caveat here. Never just assume a neurological change in an older adult is just aging. Always rule out other causes. First infections, medication side effects, new pathology.
Okay, noted. But what are some typical age-related changes?
In the CNS, there's some gradual neuron loss. The ventricles might enlarge slightly, brain weight might decrease, blood flow can lessen, and CSF production might go down. Clinically, this can contribute to things like altered balance, maybe some dizziness or vertigo, increased risk of postural hypotension, changes in gait, sometimes slower processing, and definitely a reduced ability to cope with extreme temperatures, making them prone to hyper or hypothermia.
The PNS.
Myelin can degenerate a bit, slowing nerve conduction. Neuromuscular activity might become less efficient. So you see slower reaction times, sometimes decreased sensation, touch, pain, temperature, taste, smell, maybe some muscle strength decline. All of this really adds up to problems with balance and coordination, which is why fall risk is such a major concern in older adults. Our assessments need to be extra thorough.
Absolutely, which brings us perfectly to the assessment itself, the core nursing function. Starting with subjective data, the patient's story.
Right. And rule number 1, is this an emergency? Is their level of consciousness dropping fast? Address that immediately. Then, figure out if the patient can give you reliable info. If not, get family involved. Ask open-ended questions. Avoid leading them. You need to know how it started, how it progressed, the characteristics of the symptoms, get history of TBI, stroke, any known neurodiseases.
Let's bring in JK again, our 57-year-old. She came in with severe headaches for weeks, a visual field deficit upper left quadrant noted by her provider, and then she had a seizure during that visit.
Okay, boom. Red flags everywhere, headache, visual changes, and a seizure in someone with no prior history. That screams, investigate the brain urgently.
Exactly. What other history is important?
Growth and development, definitely family history. Think Huntington's, MS, Parkinson's, Alzheimer's, epilepsy. Full medication list, including over-the-counters and herbals, so many potential neuro side effects, and any past surgeries, especially neurosurgery.
And we use functional health patterns to see the bigger picture, right?
All right.
How does this neurological issue affect their life?
Precisely. Like nutritional, metabolic. Can they chew, swallow safely? Do they have facial paralysis affecting eating? Muscle coordination issues. Are they getting enough B vitamins, especially B12? Early nutrition is critical after brain injury.
Elimination?
Huge. Bowel or bladder incontinence or retention. Very common after stroke, head injury, spinal cord injury, MS, dementia, sudden onset incontinence. That could be an emergency, like Cauda-Equina syndrome.
Activity exercise seems obvious.
Yeah.
Mobility, strength, coordination, fall risk. What about sleep rest?
Pain, muscle spasms, weakness, even hallucinations can wreck sleep patterns. Important to ask about.
Cognitive perceptual is central here, right? Memory, language, judgment.
Absolutely. Assessing orientation, memory recall, ability to calculate, like count backward from 100 by 7's problem solving, insight. Asking about judgment, like what would you do if you smelled smoke in your house? Using tools like the MMSE or MoCA gives you a baseline. And always be alert for delirium, that acute confusion often signals an underlying medical problem like an infection. Use a tool like the CAM to screen for it.
And the psychosocial patterns. Self-perception, roles, relationships, coping.
Neurologic problems can devastate these areas. Think about personality changes after a TBI, role changes after a stroke, the impact on sexuality, the immense stress on patients and caregivers. Sensitive assessment is key, often needing input from family because the patient might lack insight anosognosia.
So back to JK. We found out she had no prior seizures or migraines, just mild hypertension. But importantly, she reported feeling depressed and scared about what was happening. That emotional piece is vital for planning her care.
Definitely. Okay, so that's subjective. Now, the objective data, the hands-on physical assessment. We need a consistent approach.
6 categories.
Right. Mental status, cranial nerves, motor system, sensory system, cerebellar function, and reflexes. Doing it systematically ensures you don't miss things.
Mental status starts right away.
The second you walk in the room. General appearance. Are they alert? Drowsy? Comatose? How's their motor activity? Posture? Hygiene, poor grooming can hint at cognitive decline or depression. Facial expression. Speech, is it clear, slurred, nonsensical? Then cognition. Orientation, person, place, time, situation. Memory, short and long term. General knowledge, insight, judgment. And again, screen for delirium.
Okay. Then the cranial nerves. The detailed check. CNI.
Olfactory. Smell. Use something non-irritating and familiar like coffee or vanilla. Test each nostril separately. Anosmia, loss of smell, can be an early sign in Parkinson's or Alzheimer's.
CN2. Optic. Vision.
Check visual acuity, Snellen chart, or just reading print. And visual fields by confrontation, comparing their peripheral vision to yours. Deficits like hemianopsia or quadrantinopia point to specific brain pathways being affected. JK's upper left quadrantinopia is a huge clue.
CNs 3, 4, and 6. Eye movements.
Oculomotor, trochlear, abducens test together by having them follow your finger through the 6 cardinal positions of gaze. Watch for smooth, parallel movement. Note any nystagmus, that jerky eye movement. Check pupils. Size, shape, equality, reaction to light, direct and consensual. And accommodation. Remember, parallel.
And you mentioned a critical alert for CN3.
Yes. Oculomotor nerve compression, often from brain swelling pushing down, causes the pupil on that side to dilate and become sluggish or non-reactive. A dilated fixed pupil is a neurological emergency, signaling potential herniation. Also look for ptosis, a drooping eyelid, another CN3 sign.
Okay, critical. CNV trigeminal.
Sensory to the face, 3 branches, ophthalmic, maxillary, mandibular test, light touch, maybe sharp dull, and motor for chewing, clenched teeth, feel masseter muscle. The corneal reflex involves V, sensory, and 7, motor.
CN7. Facial.
Motor for facial expressions. Ask them to raise eyebrows, frown, close eyes tightly against resistance, smile, puff out cheeks. Look for symmetry. Weakness here is very noticeable.
CN8. Vestibulocochlear.
Hearing whisper test, finger rustle, maybe Weberin if needed. Vestibular part balance isn't usually formally tested unless they report dizziness or unsteadiness.
CNIX and X. Glossopharyngeal and vagus.
Tested together, check gag reflex, touch back of throat lightly, vital for assessing aspiration risk. Have them say, ah, watch palate and uvula rise symmetrically. Cough reflex is also vagus nerve mediated.
CNII. Accessory.
Shoulder shrug against resistance, turn head against resistance. Test trapezius and sternocleidomastoid muscles.
And finally, CN12. Hypoglossal.
Tongue movement. Stick tongue out should be midline. Move it side to side. Push tongue against cheek against resistance. Deviation points to weakness on that side.
Wow, that's a thorough check. Next category, motor system.
Strength, tone, coordination. Test strength in all 4 limbs, push-pull against resistance. Grade it 0 to 5. A great subtle test for upper limb weakness is pronator drift. Arms out, palms up, eyes closed. If an arm drifts down or the palm turns inward, pronates, that suggests weakness, often from a contralateral cortical lesion. Assessed passively. Move their limbs through range of motion. Feel for resistance. Is it decreased hypertonia, flaccidity, or increased hypertonia, spasticity, rigidity? Note any involuntary movements, tremors, tecs, chorea.
Cerebellar function, balance and coordination.
Observe their posture and gait stride, rhythm, arm swing. Are they steady? At risk for falls. Test coordination with finger to nose, heel to shin, rapid alternating movements like flipping hands, maybe shallow knee bends, and listen to their speech. Dysarthria, slurred speech, can be cerebellar.
Okay. Sensory system next. Eyes closed for this.
Definitely. Avoid giving clues. Test light touch, cotton ball, pain, sharp versus dull with the pin carefully. Maybe temperature if pain sensation is off. Check if they can feel stimuli equally on both sides, or if one side is less sensitive. Extinction.
What about vibration and position sense?
Use a tuning fork on bony spots like ankles, wrists. Ask when vibration stops. For proprioception, position sense, move their big toe or finger up or down, have them tell you which way it moved. The Romberg test checks this too, along with vestibular function. Stand feet together, arms at sides, first eyes open, then closed. Swaying or falling only with eyes closed is a positive Romberg. Safety first here, be ready to catch them.
Cortical sensory functions, testing the parietal lobe.
Right, more complex processing. Stereognosis, identify a familiar object like a key or coin by touch alone. Graphesthesia, identify a number traced on their palm. 2-point discrimination, can they tell if they're being touched by 1 point or 2 points close together? Varies by body part.
Last category, reflexes.
Deep tendon reflexes, biceps, triceps, brachioradialis, patellar, knee jerk, Achilles, ankle jerk. Tap the tendon, watch the muscle contract, grade them 0, absent to 4+, or 5+, hyperactive, often with clonus. Look for symmetry. That's a sustained rhythmic beating or contraction after you quickly stretch the muscle, like dorsiflexing the foot. It's abnormal, indicates hyperreflexia, usually UMN lesion.
And the Babinski sign.
That's the plantar response. Stroke the sole of the foot. Normal is toes curl down, flexor response. Abnormal in adults is the big toe goes up, other toes fan out. That's an extensor plantar response. Or Babinski sign, indicates an upper motor neuron lesion. Critical finding.
Okay, so JK's objective findings. Besides vital signs being stable, she was alert, oriented, anxious. Strength was 55 everywhere, but that key finding was the visual field deficit in the upper left quadrant. It matched her subjective report perfectly.
Exactly. That detailed assessment points you right towards needing imaging to see what's happening in that parieto-occipital region on the right side of her brain, which leads us to diagnostic studies.
Right. To confirm what we suspect, CSF analysis first.
Cerebrospinal fluid tells us a lot. We look at its appearance, should be clear, colorless. Pressure, cell count, should be almost none. Protein, glucose. It's obtained via lumbar puncture, LP, or spinal tap.
Needle in the back. What are the big nursing points?
Huge EE1. Check for signs of increased intracranial pressure before the procedure. An LP with high ICP can cause the brain to shift downward herniation, which is catastrophic. So assess neurostatus carefully, check for papilledema if possible. Also, contraindicated if there's skin infection at the puncture site.
What about during and after?
Pre-procedure, get baseline vitals, neurocheck. Confirm consent, check coagulation studies, teach the patient what to expect, positioning, side lying, knees to chest, or leaning over table, temporary paintingling, ensure they void beforehand. Post-procedure, monitor vital signs and neurostatus frequently. Check the site for bleeding or CSF leak. Keep the patient lying flat for usually few hours, depending on protocol, to minimize risk of spinal headache. Encourage fluids. Teach them to report severe headache, numbness, tingling, leg weakness, or trouble voiding.
Okay, vital precautions. Then radiology, CT scans.
Computed tomography. Fast, great for seeing acute bleeds, skull fractures, large tumors, edema. Often the first test in emergency like stroke or head trauma may use IV contrast.
Contrast means?
Check for allergies, especially iodine or shellfish. Check kidney function, BUN, creatinine, because contrast can be hard on kidneys. If they're on metformin, it often needs to be held. Ensure hydration afterwards to flush contrast out. Patient needs to lie still.
MRI.
Magnetic resonance imaging uses magnets, no radiation, gives much better detail of soft tissues than CT. Excellent for seeing smaller strokes, MS plaques, tumors, spinal cord issues. MRI looks specifically at blood vessels. fMRI looks at brain activity.
The safety checks for MRI.
Absolutely. Huge E magnetic field. Screen carefully for any metal implants, pacemakers, often an absolute contraindication. Aneurysm clips, cochlear implants, metal fragments. Remove all jewelry, patches with metal foil. Assess for claustrophobia, may need sedation. Patient needs to lie very still for quite a while. Gadolinium contrast might be used, less allergy risk than iodine, but still need to check kidney function.
Cerebral angiography.
That's the gold standard for visualizing blood vessels, aneurysms, arteriovenous malformations, AVMs. It's invasive catheter inserted usually in the groin, threaded up to the neck arteries, contrast injected.
Nursing care for that.
Assess stroke risk beforehand. NPO. Patient needs to be still. Warn them about warm, flushed feeling with contrast. Afterwards is key. Frequent neurochecks and vital signs, Q15, 30 minutes initially. Monitor the puncture site closely for bleeding or hematoma. Keep the legs straight. Bed rest, usually for 6 hours, unless a closure device is used. Check pulses distal to the site.
Myelogram.
X-ray or CT of the spinal canal after injecting contrast into the subarachnoid space. Looks for herniated discs, tumors compressing the cord. Post-procedure care, similar to LP, keep flat for a bit, encourage fluids, monitor for headache.
PT and SPECT scans.
Positron emission tomography and single photon emission computed tomography. They measure metabolic activity or blood flow, used for things like evaluating seizures, dementia like Alzheimer's, tumors, stroke recovery. Patient needs to avoid sedatives beforehand.
And ultrasound.
Non-invasive. Carotid duplex scans look at blood flow through carotid arteries in the neck, checking for stenosis. Transcranial Doppler, TCD, looks at blood flow velocity inside the brain's arteries. Quick bedside tests often.
Okay, last category, electrographic studies. EEG.
Electroencephalogram. Records the brain's electrical activity via electrodes on the scalp. Main use is for diagnosing seizure disorders, evaluating altered consciousness, confirming brain death. Non-invasive. Assure patient no shock involved. May need to withhold caffeine or certain meds beforehand, depending on the reason for the test.
EMG and nerve conduction studies.
Electromyography measures electrical activity within muscles, often using small needles. Nerve conduction studies measure how fast electrical impulses travel along nerves, used together to diagnose muscle diseases like muscular dystrophy or nerve problems like peripheral neuropathy, carpal tunnel, can be uncomfortable due to needles. Avoid stimulants like caffeine before.
So for JK, after that assessment pointing to the right parieto-occipital area, what did her diagnostics show?
Her MRI and MRA provided the answer. They revealed a temporal parietal glioblastoma extending into the occipital lobes.
Glioblastoma, a type of brain tumor.
Yes, unfortunately, a very aggressive type. But this is the aha moment. It explains everything. The location explains the headaches and the upper left visual field deficit, since vision pathways cross. And the tumor itself irritating the brain tissue caused the seizure. Assessment led to targeted diagnostics, which gave the diagnosis. Now, nursing care becomes focused on managing symptoms, preparing for treatment, and supporting JK and her family.
That perfectly illustrates the whole process. Okay, let's wrap up. Key takeaways from today's deep dive.
We covered a lot. The basic CNS PNS structure, neuron function with that speedy saltatory conduction, the vital support from glial cells, really understanding the difference between upper and lower motor neuron signs, spasticity versus flaccidity, hyper versus hypo reflexes.
And the systematic assessment subjective history using functional patterns and the objective exam covering mental status, all 12 cranial nerves, especially those emergency signs like CN3 pupil changes, motor, sensory, cerebellar, and reflexes like Babinski.
Absolutely. Plus the major protective elements, CSF circulation, the selective blood-brain barrier, meninges, bone, and then the diagnostics, knowing the purpose, the crucial nursing responsibilities, and safety precautions for things like LP, CT-MRI with contrast, angiography. JK's case showed how it all fits together.
And this isn't just academic, right? This is about understanding what's happening with your patient, seeing those subtle changes, knowing when to worry, when to act, how to keep them safe. It empowers your practice.
Exactly. It's the foundation for providing truly excellent neurological nursing care.
So a final thought for our listeners to mull over.
Well, think about how fast technology is moving in neuroscience. We have amazing imaging, better understanding of neuroplasticity, even brain-computer interfaces starting to emerge. How do you think these advances will change not just diagnosis and treatment, but maybe even our understanding of consciousness, memory, the self? And how will that impact your future role as a nurse caring for these patients?
Wow, deep stuff to consider. The future of neuronursing is definitely exciting and challenging.
For sure.
Keep digging, keep learning, keep asking those questions. Thank you so much for joining us on this deep dive into the nervous system.
Thanks for listening.
We look forward to exploring more vital nursing topics with you soon.